Hi everyone, my name's Libby. I'm one of the FFP students and I did the SSM in gynecology, oncology, laparoscopic and robotic surgery. And today I'm going to give you a quick 10-minute presentation on the topic that I chose, which was the pneumoperitoneum in laparoscopic surgery. So today we're going to go through three main things. Briefly, we're going to talk about how you create a pneumoperitoneum, just in case you haven't seen this before. Then we're going to mainly talk about some of the system of changes associated with the pneumoperitoneum, so looking at this from the anaesthetic side. And then we're going to talk about a potential alternative to creating a pneumoperitoneum, as it's something I read about and I thought was quite interesting. So creating a pneumoperitoneum is called insufflation. And the reason that we do this, if you think about it, is because we want to create space in the abdomen to visualize all the organs. So the camera's got a really good view of all the organs in the abdomen and the pelvic cavity, and so that the instruments can be moved around in the abdomen as well, and it makes the procedure much easier. So briefly, how to create the pneumoperitoneum. The patient needs to be lying supine in the dorsal lithotomy position for gynecology surgery. Then the surgeon would insert a Veress needle into the umbilicus or the palm's point at 90 degrees. And then the next thing to do is to check the needle is in the peritoneum and not in any other layers of the abdominal wall, for example, and not in any organs or any blood vessels. So there are various ways to do this, including aspiration, and you can also check the opening pressure as well. But we won't go through all of those today. And then you would insufflate with a gas to create a pressure of 20 millimeters of mercury. So that's a bit of a whistle-stop tour. You should see more of that in your surgery rotation. So definitely ask the surgeon about that if you want to find out any more. But something that I want us to think about today is what gas is used to create the pneumoperitoneum. So have a think about it. Is it oxygen? Is it nitrous oxide? Is it carbon dioxide? Or is it argon? And we'll go through the answer now. So to create the pneumoperitoneum, the gas used is carbon dioxide. There are a few reasons for this. Firstly, it's because it's got high blood solubility. So as it's absorbed into the bloodstream, it means that it lowers the risk of a gas embolism. Carbon dioxide also does not support combustion, which is good because you can imagine in laparoscopic surgery, if you used oxygen to create the pneumoperitoneum, that when you're using the heat devices, that probably wouldn't end very well. And it's also cheap and it's also non-toxic. So carbon dioxide is the gas used. So we've spoken a little bit about how to create the pneumoperitoneum, why we do it, and the gas used. And now we're going to move on to talk about the impacts of the pneumoperitoneum. So the pneumoperitoneum caused by carbon dioxide has two primary consequences. So you can have a think now if you want to have a think about what two of those might be. So the first one is an increased intra-abdominal pressure. So when you create the pneumoperitoneum, you're inserting the gas into the abdomen, and that's going to put lots of pressure inside the abdomen. And then also hypercapnia, because the carbon dioxide gets absorbed into the body and it's at a higher level than it usually would be. So we're now going to go through briefly the consequences of an increased intra-abdominal pressure and the consequences of hypercapnia. And then we're going to talk about those a little bit more in depth in some system changes. So for the increased intra-abdominal pressure, you can imagine that if you're increasing the pressure in the abdomen, you're going to compress lots of the structures and the organs around. So that includes compressing the inferior vena cava, the aorta. It's going to include compressing blood flow to the kidney, blood flow to the liver, spleen, pancreas, and GI tract. It's also going to displace the diaphragm. So you can imagine that you're increasing the pressure in the abdomen and your diaphragm is going to get pushed up. And then if we think about the increased levels of carbon dioxide, so it gets absorbed from the pneumoperitoneum, and because of this, your body's minute ventilation increases by up to 60%. So it's trying to make sure that the carbon dioxide levels are kept at a normal range, and it does that by increasing the minute ventilation. And also carbon dioxide might activate the sympathetic nervous system, which in turn has lots of consequences like increased heart rate, blood pressure, myocardial activity. So there's always a risk of arrhythmias there. So we're going to move on now to talking about the different systems, and we're going to start with the cardiovascular system, which you could argue has some of the main complications of creating a pneumoperitoneum. So if we start by how the increased intra-abdominal pressure has an impact on the cardiovascular system, it's got three main ways really. So the first one is that it compresses the abdominal aorta and activates the renin-angiotensin-aldosterone system. So in turn, this then increases systemic vascular resistance, which means that the tissues in the body are getting slightly less blood supply, which isn't always ideal. Secondly, it can compress the inferior vena cava, which will decrease the preload on the heart, so decreases the amount of blood going back to the heart, and in turn this will decrease the cardiac output. And thirdly, the increased intra-abdominal pressure. An impact of this, is that when you're creating the pneumoperitoneum, you would then stretch the peritoneum during inserting the varus needle, for example, and that can stimulate the vagal nerve to lead to bradyarrhythmias, so the heart slowing down. And then if we think about how the carbon dioxide might impact the cardiovascular system, you can increase the carbon dioxide and that releases catecholamines as well, and that might lead to tachyarrhythmias. So we can see already that we've got lots of different impacts on the cardiovascular system for the anaesthetist to think about. And if we move on to the respiratory system, so the increased intra-abdominal pressure, as we've said already, will displace the diaphragm will move upwards. And a result of that is that the pressure in the thorax will increase, and you can imagine that if the pressure in the thorax increases, then the amount that the lungs can expand reduces, and so that's called a reduced pulmonary compliance. And in worst case scenario, this can lead to things like ventilation perfusion mismatches, and can also lead to collapses of part or whole of lungs. And secondly, for the respiratory system, the carbon dioxide increases. And as we said before, this increases the minute ventilation, in turn the rest rate increases to try and get rid of that carbon dioxide. This can lead to something called subcutaneous emphysema, which is gas collecting under the skin. And if this is left for a long period of time, this can cause respiratory acidosis. You can imagine all of these consequences are worsened by the Trendelenburg position, which is in gynecology surgery where the patient is placed head down. So you can imagine if the patient is head down, all that pressure is just going to increase because all the organs are pushing on the diaphragm, and so you can imagine that exacerbates all of these changes. So moving on to the renal and the splanchnic systems. So for the renal, as we've said already, you can get compression of the renal arteries, and as a result of this, reduced renal blood flow, and then there is a rare risk of an acute kidney injury occurring. You can imagine if a patient already has chronic kidney disease that this risk will be higher already, so something for the anaesthetist to think about. And then there's also a decrease in the macro and the microcirculation of the splanchnic system, so that means that the tissues will become less perfused, so that's the tissues of the GI tract, the liver, the spleen, the pancreas, and again that can lead to tissue acidosis. And an important thing to consider is that over 20 millimeters of mercury pressure can lead to up to 40% reduction in the GI mucosal and the mesenteric flow. And again, that can cause acidosis, as we said. So finally, moving on to some neurological effects. As we've said, linking to the respiratory complications, as we've got increased thoracic pressure, that can lead to a limit in the cerebral venous drainage, because obviously our brain drains into the blood in our brain drains into our thorax, and if we've got increased pressure in the thorax, it might mean that that blood is less able to drain, and so there's a risk of cerebral edema. So this is a bit of a summary that you can read in your own time. As I said, there's lots going on here, so this is really just a little bit of an overview just to give you an idea. But yeah, there are many, many risks associated with creating a pneumoperitoneum, and so you can read through this in your own time. A few special mentions now to some post-operative impacts of creating a pneumoperitoneum. So sometimes the stretch of the diaphragm can aggravate the supraclavicular nerve, and that can cause shoulder pain. And so that can be one of the post-operative implications of a pneumoperitoneum. So the second one on here is not 100% confirmed, but people do suspect that during the operation, when you've got that increased intra-abdominal pressure, you have a decreased blood flow to the GI tract, and you get irritation of the mucosa caused by that increased intra-abdominal pressure, and that can lead to post-operative nausea and vomiting. So a pneumoperitoneum can be one of the contributors to post-operative nausea and vomiting. So if we want to think about how to sort of reduce the effects of this carbon dioxide pneumoperitoneum, some of the things a surgeon can do, for example, is to apply the pneumoperitoneum in the supine position, so the patient lying flat rather than head down or head up, depending on the type of surgery. Keep the pressure below 15 millimeters of mercury as much as possible. In gynecology surgery, I know they like to have it a little bit higher. So yeah, just always a consideration. But I think most surgeons keep it at about 20. And also to have slow carbon dioxide insufflation as well. So now we're going to move on to the final part, and we're just going to talk about some alternatives to a carbon dioxide pneumoperitoneum. So the reason that you might want an alternative might be, say, for example, if a patient already has lots of cardiovascular conditions, and maybe a pneumoperitoneum might be really risky for them, for example. So one of the alternatives is something called a gasless TLH. So I read a paper about total laparoscopic hysterectomies and comparing traditional laparoscopic TLHs to gasless TLHs. And you might think, well, how do they do this? So they use these, instead of inserting gas into the abdomen, they use these J-shaped retractors to retract the abdominal wall via the umbilicus. And it's actually shown to be feasible for a TLH, and it might help to reduce some of the issues surrounding the carbon dioxide pneumoperitoneum. So it's actually shown that there's no significant difference in, say, operation time, setup time, blood loss, and there's no serious complications or anything either. So this is what it would look like. So you can see the J-shaped retractors are used here to open the abdomen up rather than inserting the gas. And the next slide here shows the view inside the abdomen. So you can see an anterior and posterior view of the uterus there. And you do get quite a good view here. Some of the things to consider is that there is slightly less space than in a conventional laparoscopic surgery. And you might get, say, bowels in the way. But some of the things to combat that might be using bowel prep before, and also considering the surgery for people with, say, a lower BMI, so that you can maximise the amount of space that you've got in the abdomen. And the paper also suggested maybe using gauze to move the bowels out of the way as well. So obviously that's not for everyone, but I thought that was a good little example of how you can create space in the abdomen without inserting gas. So yeah, just something to consider there. So in a bit of a summary, a pneumoperitoneum can cause increased intra-abdominal pressure and hypercapnia as the main two consequences. And it can cause significant hemodynamic, cardiopulmonary and physiological changes in a variety of systems. So I hope that was a good little whistle-stop tour of the pneumoperitoneum. And if you've got any questions, I'm sure you can ask the teaching fellows or Mr. Abdul as well. So thank you very much.